Okay, first of all, I must give my profuse apologies. I don't know why I had it in my head that this was happening later this evening, so I was going to do this from home. As it is, I'm currently in clinic and have been here since about 2 o'clock this afternoon, dealing with patients. So I suppose that itself is a reflection of the impact of COVID. And how it's changed general practice. The other thing that's very different is having been here, as I say, since 2007, and I've acted before that, at least not in the usual sense of seeing patients. I have videos and, well, one on video, a couple of images of patients, but mostly I'm transformation of my practice, and it's a transformation remained that way since. Now, how this all kind of first impacted on general practice, and then I would like to talk you through a few things that have been done where general practice has tried to adapt to this dramatically new situation for us, and talk about sort of where we are now, and perhaps speculate a little bit about how things might be in the future, because I think our future is not going to go back to our past, as it were, and I think that's true of the society in general, but I think general practice is going to be changed by this in more permanent ways as well. So just go back to early March, and I suppose the first inkling we got, along with the rest of the country, if you like, was the initial few cases. And I apologize because I had a little video of one of my colleagues, whom I mentioned actually anyway, Dr. Nuala O'Connor. Nuala O'Connor already had a position of being the person in the Irish College of General Practitioners who had a sort of specific lead in the area of antimicrobials and infection. So Nuala was identified by the Irish College of General Practitioners to be a sort of spokesperson in relation to this matter. And as I say, I can't show you it, but there's a little video from, I think, about the 4th or 5th of March, where Nuala said, oh, there's 5 cases of this in the country. There's nothing too much to worry about. We will possibly come across it, but we will deal with it. We've done our PP and we'll be fine. Innocent times with no idea how this was going to scale up to what it is now. Having said that, it did very quickly evolve from that, as I said, literally in the first few weeks of March, to perhaps even by the 2nd week of March, it was already apparent that this was going to become much more serious matter than Nuala portrayed in that brief RTE interview. And one of the things that really brought it home to the GP community here was, in fact, the death of one of our GP colleagues in Italy, in Lombardy. He was a GP in Condogno, which was the sort of epicenter of it in early March and April. And he was a GP who was well known because he had an international profile. He was a leader of a local GP society. So he was known to several of us, and he died from COVID. And also what was clear from what we heard of his story was that part of the problem in that part of Italy, and part of the problem that general practice was so badly impacted, including his sad demise, was the lack of preparedness. They just didn't know what they were dealing with at that time. So fairly quickly, and I'd say certainly before, on around about the 12th, 13th of March, which is the time we went into lockdown in the country, general practice did something which was, again, totally antithetical to us in some ways, as we shut our doors. We did that obviously because of the risk of contamination and the risk of spreading this infection through our practices. So we couldn't let people in to our waiting rooms. We had to start regulating people coming in. We had to deep clean our premises and then start preparing for the reception of patients back into the practice, but in a much more, if you like, infection control oriented way. So basically we had to, many practices, we sort of did things like organize into clean spaces and potentially contaminated spaces. We had to up our act in terms of infection control across the board. And again, as was common with the health service in general, even though we, as I say, literally shut our doors, it also happened at that time patients disappeared as well. So our regular, what are now being referred to as non-COVID or our non-COVID work disappeared as well. And I think that was just a reaction in the population in general. And they knew that this was a highly infectious disease. They didn't know too much about it, except that it was infectious and it was potentially fatal. So they didn't want to go to any health premises, doctor's surgeries, or to hospitals. So it took us a while to get our heads around what was happening and adapt. And as I say, one of the things that we did to adapt was to set up what are called COVID assessment hubs. So basically the thinking behind those was that if you had a patient who, and I should say by that stage we were dealing with most patients over the phone, we were doing a lot of telephone triage, and we were essentially triaging people into things that could be dealt with over the phone, things that needed to go to hospital, and things which we weren't sure whether they need to go to hospital or whether they could safely come to us. But in the mix, if you like, there was potential for patients with COVID that we didn't want to be bringing onto our premises. So in collaboration with the HSE and indeed academic departments of general practice and the Irish College of General Practitioners, a number of what were called COVID assessment hubs were set up, or community COVID assessment hubs. These were set up around the country, and the idea was that if we had someone who rang the surgery and you felt perhaps had COVID and you wanted to get them assessed, but they weren't, if they were critically ill with COVID, of course they'd go straight to hospital. But if they were sort of somewhat ill, possibly COVID, not sure, then we could send them to these hubs where they were seen by GPs in the hub, but the GPs had the backup of nursing services, they'd backup of IT, they'd backup of ready access to the ambulance service and the hospital, and everyone was fully equipped in full PPE. One of the things that we contributed to that actually as an academic department was, again, along with the other academic departments throughout the country, we were involved extensively in the training up of GPs and indeed GP registrars to man these COVID hubs. So that was something that occurred in late March, early April. Again, very unusual, if you like, the extent to which something like that was put together so rapidly, and marvelous collaboration between the various parties involved. So that's, again, one of the, I suppose, slight positives of COVID. It's just how quickly people have been able to flex and adapt and reorganize and reorientate services. And that's something we're continuing to do. But as I say, it was something that was affected remarkably quickly back then in the early days. So then following on from that, there were a number of other initiatives. And again, one of the lead organizations here was the Irish College of General Practitioners. So the Irish College of General Practitioners, first of all, as I said, they were involved in the setting up the COVID hubs, and they're setting up the training for the COVID hubs. In addition to that, they also established a series of webinars, which happened on an almost, well, in fact, they're happening several times a week. It eventually settled down to a weekly basis. And at these webinars, they were, again, giving information about COVID and keeping us up to date with all the latest information, the latest guidelines, and so on. And they were, again, remarkably successful. So these were seminars that were done like this over Zoom. The attendance at them was phenomenal. I mean, there are about between 2,500 and 3,000 GPs in the country in total, and on the average webinar, there's over 1,000 GPs. They've actually had up to 2,000 GPs on webinars. So again, fantastic, institution of an educational initiative, incredibly rapidly and very, very well received and enthusiastically taken up by GPs, which is one of the reasons why I think Irish GPs are probably better than average, shall we say, in terms of their knowledge of this condition and how to manage it in a community setting, because we have had this, as I say, tremendous input of education. And the education has been provided by all and sundry. In fact, on one of the webinars, we had Michael Ryan from the WHO, who you might have seen. He's an Irish graduate, but he works in the WHO. He's one of their key people. So, as I say, we had that input from the Irish College. Another thing that the Irish College did as well was they established on their website what they call a COVID hub. And that again contains all the information that GPs might need to access about COVID. So it gives links to all the different health service executive websites those that come from the Department of Health. So anyone who puts out information or community surveillance of general practitioner website. Another aspect of their, again, what they call the COVID information hub, if you like, on the college website, has been a collation of evidence led very much by the academic department of general practice, including my own. And basically what we do is we receive questions from GPs, very specific questions about, you know, how do we manage pregnancy in COVID? How do we triage patients safely? Any question, and again, how do we manage our practice? And again, there's obviously financial aspects too. How do we claim COVID payments for treating patients with COVID, and so on? So basically, all this information again is the questions come in. They are sent to an academic person who then goes through the literature, word literature, which again is rapidly expanding, of course, in relation to this disease. We collate that evidence base and we distill it into an answer to the question, and that's posted up on the ICGP website. So again, that's been another tremendous initiative which has helped GPs adapt and deal with the situation that was emerging. Another thing that the Irish College were involved with, but involved more extensively colleagues from Trinity College in Dublin, and a pre-existing sort of online forum that was in existence called GP Buddy. And they've come together to set up something which they call the COVID tracker. And basically what that does, and has proven to be very useful, is they get each GP, or any GP wants to volunteer. They've got 200 or 300 GPs doing this, sending them information on a daily basis of patients they've seen who might have COVID, patients who've been sent for testing, patients who have called about COVID but probably don't have COVID, and so on. So they basically get a very brief information, but on a daily basis. 100 GPs dispersed throughout the country as to what they're seeing, if you like. So it actually acts as a sort of early warning system, and it's very much valued by our colleagues in public health now, and NEFIT are receiving this information collated by the COVID tracker initiative by the GPs, and basically that has been very useful in terms of flagging them, you know, where it's emerging. And we've seen that, you know, as hotspots have appeared. Most recently, I was around the border counties, prior to that in Dublin, prior to that in Kildare. This was all apparent from the GP tracker, which, as I say, is collated by GPs and shared with public health and others. Another group of colleagues in the University of Limerick have another group of academic GPs, if you like, have also established something called COVID Watch. And again, what COVID Watch is about scanning the literature and keeping an eye on all the different websites to give us a picture of the flavour of the international scene. So they've tracked how Ireland is doing compared to other European countries, other countries around the world, and in relation to all the different parameters. So again, it's quite useful for us as GPs to have ready access to the data on case numbers, test positivity, hospitalizations, deaths, and so on from Ireland, and how that compares with other countries. So, so as I say, the GP community and the academic GP community, of which I'm part, I think we're justified in having some pride in how we've adapted to this situation and how we've contributed to, as I say, the adaptation that had to be made in relation to the delivery of care and the coping with this pandemic. So just to bring you up to date then at how things are currently. So basically, as I say, things have stabilized now a little bit. Oh, sorry, one of the things I did want to mention as well, I meant to get back to my colleague, Dr. Nuala O'Connor. So one of the things that Dr. Nuala O'Connor did, as I say, as well as being our spokesperson on media and so on, a role, I have to say, she shared with another Cork GP. I should say that Nuala O'Connor's based in Cork. Another Cork GP has been very prominent in the media, and this, of course, has been our ICGP president, Dr. Mary Favier, another Cork GP. But Nuala, as I say, she has also, in collaboration with HSE colleagues, produced a range of training videos on things like PPE, and as I say, there's videos on how to do what might be called full PPE and then partial PPE, and kind of what can be done when you don't need PPE, but the other things you need to do regardless of perceived risk, things like mask wearing and so on. But again, and I suppose this shows what a small and intimate community the GP community can be. When you don the full PEP, that's the kind of the masks, the visor, the gloves, the gown, the boots, the whole lot. When you do that entire kind of full PEP, as it would be called elsewhere, we call that the full NULA. And then there's a sort of a lesser version of it where you wear masks, gloves, and an apron, maybe not necessarily a gown, and that's been nicknamed the mini NULA. And then when you just have, as I say, the mask and ordinary sanitization, so we call that the micro NULA. So our colleagues have taken on a certain persona in all of this. So anyway, getting back to where we are now. So what just, I suppose, talking my own practice, but I know it's reasonably typical. We are, as I say, still doing a very substantial amount of online or virtual consultations. We're using video consultation a little bit more. We're certainly using a lot more, getting patients to send us images from their smartphones, which again, the technology has been a godsend here. I don't know how we would have coped with this pandemic without modern technology, but we get people to send us in images or videos when they can, or we can have a video consultation. But still, I'd say the figures are a bit variable in different places, but it seems that about up to 70% of consultation with patients are now happening virtually, and particularly, say, over the phone, the vast majority. But we have also managed to organize ourselves to see patients face to face, and that's very important. In fact, it's something we quickly realized in the early days of the shutdown, that we were losing, if you like, control or monitoring of a lot of patients who couldn't be monitored over the phone, if you like, or needed procedures to be done that were not being done, and we're, as I say, running risks of people getting into trouble with non-COVID disease. Have what, again, in our practice, and are referred to as Ppe Sessions. So basically, they're now about 30% of our consultations are with a nurse or a doctor who's in full Ppe, and again, called the full NULA. And basically, that's when they see then people who, as I say, need to be seen face to face. The priority groups for that, for us, have been childhood vaccinations. They now are all back up and running and almost caught up with the lag that occurred there. We have our antenatal clinics back up and running. We have also patients then coming in for what we call chronic disease management, and that basically our elderly population who have chronic diseases like COPD, asthma, diabetes, and so on. And basically, we're getting them in now to get them monitored and under review. We've also got things up and running again in relation to doing blood tests for people who are doing phlebotomy, for people who are, again, got, say, conditions which need to be monitored. Yeah, I suppose that's, as I say, a reflection of where we're up to. And the final thing is, as I say, and this is my last slide, if you like, the PowerPoint they're not getting to see, which is around, you know, it's an ill wind that blows no good. And one of the things that's come out of this is incredibly fast tracking of something we've been looking for years, which is the idea of electronic prescribing. So historically, you know, if we wrote a prescription, we'd give it to the patient had to take it down to the chemist, leave it at the chemist for an hour, so come back to the chemist and get the medicine dispensed. And this seems ridiculous, given that we have computers. We're putting the medicines, the prescription on the computer and then printing it out and giving it to the patient. And we've been using old-fashioned dot matrix printers to do that as well, which is even more nonsensical. And then that is being taken into the chemist and typed into their computer, and then it's dispensed to the patient. But with the new system now, we can literally, when we select a medicine for the patient, let's say we want to prescribe the patient a course of antibiotics, we just, on our computer system, we can select amoxicillin, we click a button, we put in the dose and all that sort of thing, and then we click a button to identify which pharmacy the patient asks us to send it to. We press the button, and hey presto, within seconds, the prescription is appearing on the pharmacist's computer, and he can then, or he or she can then dispense the medicine. So, and the patients are astounded at this. You know, people say, "Oh, when will that be in the chemist?" And I say, "Well, you know, the chemist now has it this second." Once I press this button, the chemist has the prescription. So, as I say, that's something which is, as I say, a huge bonus. But it's also something we're not going to go back on. I mean, that's something that we wanted to happen for years anyway. And that's really the final point, in a way, is that I think there's going to be a lot of learning from this, and hopefully the day will come when we won't be all frightened out of our wits of COVID, but we'll still be delivering care to patients. And while I very much miss being able to see people face to face and to talk to people properly, shall we say, I still think we're going to, because of the increasing demand on health services generally and the increasing expectation that services will be delivered in the community as much as possible, and given that we're chronically short of GPs and nurses, I think there's going to be a permanent adaptation to remote consulting. And that, as I say, it works for many things. We've seen where it can work safely and where perhaps it's not quite ideal, and we will use it more into the future. I think the one thing we do need to develop a bit more effectively is the video consultation. That's it's available, the technology's there, but I think our systems haven't adapted to it yet. But I think in the long term, we will be using that a lot more as well. So that's the kind of things I was going to talk to you about. I hope that's a good overview of what you wanted. It might have been a little bit longer and more interesting had I had the PowerPoint, but I hope that's been at least sufficiently engaging for you. And I definitely love to take any questions you have now.
Brilliant. Thank you so much, Professor Bradley. Yeah, if anyone has any questions or anything, just send them into the chat, or you can unmute your microphone or anything if you'd prefer. So yeah, I thought that was really interesting, kind of learning about how kind of a sector that really had to adjust, like everything, to the pandemic, but really pertaining to relevant stuff to us. But yeah.
And I think what I also wanted to stress was that the extent to which GPs came together as a community, particularly organised and initiated by our college, but basically very quickly, not only did we adapt at the practice level, but we adapted as a whole GP community, and we're very supportive to each other. You know what I mean? So.
Mm-hmm. So there's some questions in the chat there. I don't know if you can see them, or I can.
I saw them, but they're kind of fleeting, because I apologize, and I haven't do this on the phone.
That's okay. I can.
Yeah. Okay. So if you read them to me, Hannah, yeah, that'd be easier.
So we have a question saying, would you like to see a permanent change to health mail after the pandemic?
Yes, absolutely. Well, as I say, yeah, health mail is the mechanism through which we do the prescribing. We also do our, I didn't mention that, but actually we do our referrals for COVID testing and our referrals to the COVID hub. They're all done through health mail. And health mail has been in place for doing referrals to hospital. Again, there have been a few services that have been up and running very effectively for years. I know one of the ones we've had for years is the pigmented lesion clinic. But now it's going to become more universal. And I think that's, again, going to be a total transformation. Is just so much expedites communication between us and hospitals and other community services and pharmacists and so on. We're not going to give that up. That's something that well, again, now we've worked out the way to do that and been doing it successfully through this period, where we're going to maintain that into the future for sure.
Yeah, definitely. And what has been the hardest part about meeting? What's the hardest part about meeting a patient over Zoom?
Well, I suppose, actually meeting over Zoom is better than about phone calls. It's the phone calls I think most of all. And I'll come back to, because there's definitely disadvantages to that I'm painfully aware of, even though they're working for a lot of things, but they're definitely not working for everything. Meeting them over Zoom, or actually, well, first of all, we don't use Zoom, of course, because Zoom isn't sufficiently secure. We have a specific secure website for video consultations, which is one, again, which was rapidly put together by the HSE and some private sector people who are already in the video consultation space, but they came on board with HSE, and we've been able to use their technology, again, very quickly within a few weeks of this all kicking off. The disadvantage, I suppose, there's obvious disadvantages in a way of, if someone has a lump, you can't feel the lump. You can see it, but you can't feel it. And that's not satisfactory. We're dependent enough on the quality of their technology as well. And again, sometimes they don't have good lighting, or they're not familiar with using the camera on the phone and so on. For some people, that's not, as I say, that's been a bit of a problem. And people can get, older people who are perhaps less comfortable with technology, for example, or indeed younger people, anyone who's not comfortable with technology, not used to using it, can get quite stressed because they know that it's important to connect with you with video, and yet if the video isn't working, or they don't know how to unmute, like I was doing earlier, that can cause stress. But the biggest thing of all is, and funny, I was reading an article about this that was written by some colleagues of mine about touch in medicine, and how touch isn't just about laying on hands and feeling lumps and bumps and so on. It's actually there is a communication, a sort of a non-verbal communication, that, and a transmission of care and concern and so on, that's transmitted by touching people. And not to be able to do that, particularly people who are distressed, or, you know, one would like to comfort, that is difficult, you know, for both doctor and patient. So is there
if there's any other questions or anything?
Oh, sorry, I meant to come back to the thing about
Sorry.
Phone consultations. Yeah, you're quite hamstrung with the phone consultations, and I suppose I've got a little bit better at it now. I know in the early days, I found that I was, you know, taking a history, for like a conventional history, but you have to go further than that. So you have to kind of try and do a remote examination by phone as well. So you know, got to ask people, you know, what does the lump feel like, and, you know, get more specific information about where things are. And, you know, it's quite difficult. I mean, if people say I have a pain in my leg, they can just point to where in their leg. But if you say over the phone where in your leg is, I mean, people get mixed up between their thigh and their shin, for example. So there are challenges in trying to get an assessment purely by over the phone. And I tell you this now, I suppose this is a warning to us all. There was an incident that happened early on, I think, that really put the frighteners on me. I got a phone call from a young lady who had complained of a headache. Over the phone, it didn't sound anything too dramatic. No, I suspect she was downplaying her symptoms. She didn't have a long history of headaches, but it didn't sound as if she had a really awful headache. Anyway, to cut a long story short, the next thing I found was a few days later, she was, my mom started to see her. I might have happened too, because, you know, she'd no signs, but I definitely would have been able to do things like take her blood pressure, look at her fundi, all sorts of things I wasn't able to do, and didn't even think I needed to do.
So I think your connection broke up a small bit there, Professor Bradley. Would you just mind repeating what you were saying?
Yeah, sorry, just saying that well, basically it was, you know, it was one of these things where, because I was trying to assess over the phone, I wasn't able to pick up on what might have been, it might have not have been there, but I might have picked up some subtle signs or indications of possible subarachnoid hemorrhage in this young woman with a headache who, as I say, after I had the phone consultation with her, ended up in hospital with a subarachnoid hemorrhage, which, quite frankly, I hadn't picked up on. And that, as I say, really put the frighteners on me about phone consultations. So and one of the things I've adapted, and just to say how you adapt to that, is I'm much more explicit now about saying, you know, this is a limited consultation. I can't do all the examination I'd normally do. So if any changes occur, if things deteriorate, if it doesn't go as I've told you I expect it to go, you must take yourself to hospital, or, you know, seek other help. So I'm much more into that. Again, what in general practice we refer to as safety netting. I probably do much more vigorous safety netting than I've ever done before.
I actually just have one question myself. So have you encountered much, or how are you kind of managing dealing with, you know, everyone's been talking a lot about post-acute COVID syndrome and the chronic effects of it, and like especially even the psychological effects of it. I know a lot of people who have been really suffering with anxiety and things in the last few months, and just curious as to what an impact that has had.
I agree. I think there are two new conditions that I've probably seen emerge. One of which is, well, I suppose, a new driver of an old condition, which is COVID-related anxiety. I've definitely seen a lot of that. And indeed COVID-related depression too. And people, not that they've had COVID, but just the worry about COVID, or, you know, the living with restrictions and so on, has definitely led to anxiety. And two things I'd say there. One is we've noticed an increase in anxiety in the patients who already had anxiety as a health problem, but we've also seen new people who've never had problem in their life before, and now they're emerging with anxiety for the first time related to COVID. So that's one sort of manifestation. But the other thing that, again, is very much coming into discussion, and funny enough, I've again seen like a clear-cut, well, what I think is a clear-cut case of it myself, literally this week, is when I say seen, talk to someone over the phone who's got long COVID, as they're calling it. So this is someone who's got ongoing manifestations of physical ill health, if you like, particularly, you know, chronic fatigue, ongoing breathlessness and so on, having been through COVID, having had COVID diagnosed and supposedly recovered from COVID, but now they're getting these longer term effects. So again, I fear that is going to become something we will see more of in the future. Thankfully, it's not terribly common. I mean, I don't know how many people I've sort of dealt with actual COVID. I'd say it's at least a couple of dozen. And this is the one and only case, thankfully, that I suspect has this long COVID syndrome.
Mm. Yeah, no, it's just really interesting and something that obviously is only kind of coming into discussion now and things, now that we're seeing people in the long term. So if anyone has any other questions, you can unmute or fire away. Otherwise, I say we might just call it there. So thank you so much, Professor Bradley, for speaking to us tonight.
And my apologies, I don't know how I got that mixed up, and I hope so. It's been a bit briefer than perhaps otherwise might have been, but I hope it's been yeah, interesting for you. I know.
No, it's been really, really interesting. Thank you so much.
Again, I want to congratulate you on this initiative. I think it's a great idea, and well done.
And yeah, on that note, I just want to thank all the other societies again. I know some of you are here tonight who were involved in it, especially the Biomed Society, the Biomedical Science Society, who really kind of drove this conference and things, and it's been really great to be a part of it. So thanks again to everyone, and yeah, I'd say we'll leave it there. Thank you all. Great.
Okay.